I'm Marc-Oliver Wright, and I'm the Director of Infection Control for North Shore University Health System. That's a health system consisting of 4 hospitals, about 100 physician offices, home health and hospice, and we serve the suburban community of northern Chicago area.
And you're here, one of the auspices that you're here under is this roundtable, which is going to happen tonight, the panel, looking at the collaboration between the lab and IPs.
Yeah.
And so tell me, so why is that of interest to you? Why is that
Well, for one thing, it's my background as a medical technologist. I'm a medical technologist with a degree in epidemiology. So when I entered into infection prevention and control, I had this immediate respect and understanding for the labs that I think goes with an educational background in laboratory sciences. But also, I was fortunate enough to start off in an institution that realized the importance of the clinical lab and the really essential role that they fill not only in diagnostic testing, but how they can partner with infection prevention programs for not only outbreak investigations, but determining the best way to test a patient for a particular organism, such that from day one in infection prevention, even as a med tech, I was working as part of a conduit between the laboratory servicing the hospital and the infection prevention program. So while I've been doing this for about 13 years, most of my time has been fortunately spent in institutions that foster that relationship. Not only for outbreak investigation purposes, where you can do environmental cultures and screening patients and do molecular typing to prove or dismiss the idea that there's ongoing transmission between patients, but you can also have a discussion when you have a relationship between clinical lab and infection prevention programs, where you can have a realistic conversation about what are the testing methods that are best used for our patient population.
I was actually going to ask you if you could tell me an incident. Where did you choose the best technology for a particular patient?
Well, so for instance, most recently in North Shore, there's been some issues around the testing for Clostridium difficile. Everyone recognizes that the testing that's been used for decades, namely the enzyme immunoassay for the toxin, is suboptimal at best. And what it encourages physicians to do is that if you get a negative result, they say, well, I don't believe that, test them again. And get another negative result, you say, well, I don't believe that, test them again. We realize that the testing is suboptimal for Clostridium difficile. So as part of our collaborative relationship with the lab, we had a discussion about what are our opportunities. And we settled on doing PCR testing for Clostridium difficile, which seems like a no-brainer. But there were other issues related that periodically clinicians will want to send specimens that are not optimal, so they'll send stool specimens that are formed and clearly the patient doesn't have C. diff, or if they do, it's not causing them disease. And we had to set up a system where we said we're going to use a better, more sensitive, more reliable test, but we're only going to test the patient once per week because, frankly, anything else is just a waste. And on the infection prevention side of that, what we had done, because the test was unreliable, is that if a patient was initially suspected of having Clostridium difficile, we would place them on contact precautions preemptively. We would get the card, hang the sign, wait for the test result to come back. What we did as a part of this, because the testing came with an increased cost, is we said, you know what, we're comfortable not only with the test, but with the turnaround time. So we're comfortable with the idea of not placing them on isolation, realizing that for that brief period of time, some patients are going to be clinically suspected of having C. diff but not be isolated. For the anticipation of a known result. We know that this patient does or does not have C. diff. So this ended up being a good business case where we were able to say to administration, yes, we want to do this more expensive test, but 1, we're going to test less frequently. 2, when we test, we're going to have the right answer. And 3, we're going to take this costly implementation of contact precautions and we're not going to implement it until we know what the test result actually is.
Wow. That's great. It's one of the things that occurs to me from our conversations is that you're making business cases, and that's not always what you see. Tell me more about that.
Well, I think one of the things that infection preventionists have struggled with for some time is a lack of comfort in talking the CFO language. You have healthcare economics that say, we're not going to do this unless we can demonstrate a return on investment. And that is the language of a business, whether you're a for-profit or not-for-profit hospital. We all have to, stay in the black and keep our jobs. So when we want to bring in new technology, or when we want to do a more aggressive program that comes up with an initial cost, we have to take into account what do we think the return on investment will be. So it's really key for infection preventionists to have a working understanding or a working relationship, particularly with their finance or purchasing departments, to know how to build these business cases for infection prevention programs. But it's even better when you have two departments going together. Most often, infection prevention programs do not necessarily report up to the same administrative arm in the hospital as the laboratory. And most of these decisions in many hospitals are made at the upper levels of the organization. So if you have two distinct departments that are working together towards a common goal and a common good, and they both approach it from not only a patient-centered standpoint, but a cost savings standpoint, you end up having two voices coming up to the top saying, this is a good idea. And that really comes out of that partnership between laboratories and infection prevention programs.
And when I think of IPs and I think of the lab, I think of cost centers, not profit centers.
Right.
So you have two cost centers going to administration, but making some kind of a cogent and convincing argument, and that turns heads, apparently.
Yeah, and we've done this, in our own center on a number of circumstances where we were able to make a proposal, show the costs up front, show the potential for return on investment, and then provide that feedback to administration on a very timely basis. And thankfully, one of the biggest ones that we did was also the most successful. If you do something like that right once, you immediately have more buy-in the next time you go to ask for the same thing, because you've already demonstrated that your ideas can and will work not only for better patient outcomes, but for financial return for the organization as well. So it's really important to do it right the first time. It builds a sense of credibility that can last for years to come.
So can you provide some guidance now on building a business case that goes up more than one vice presidency?
The actual process of building a business case is mathematics on an Excel spreadsheet. I mean, that's all there is to it. But the process of going in as a two-tiered approach is really setting realistic goals, expectation, cost, return on investment, and benefits to the organization, working collaboratively not only between the two departments of the lab and the infection prevention programs, but going out to your finance or your purchasing folks to get realistic internal numbers on which to base your estimates, and then creating one consensus statement between the two cost centers and delivering those both to your reporting structures and moving that up. So for instance, I would report to my vice president of quality and say, this is a good idea, this is why, here's how much it will cost, here's what we will gain in return, and we're going in with the lab on this. And she said, that's a great idea. And then meanwhile, the lab goes to their vice president, who is a different person, says the exact same thing, and we're talking with infection prevention, and it's a good idea, and it filters its way out.
And so once you have that approval from both of them, then you join forces and you go up.
Yeah, exactly. So you basically have, instead of disparate programs clamoring for more resources, please give me, it's please give us, and here is why. Right. It makes a much more sound argument, and it's in the language that frankly healthcare administrators can understand, and if you've done it right the first time, chances are it'll go through.
One of the things that I've heard from talking with people is that it's really hard to get into the C-suite, and it sounds like you found a way to do that.
I think yeah, that is true. We've done that historically. It's been easier for us, and that goes back to earlier successful programs. But I think you'll find that argument from infection preventionists, at least, that argument's going down. And the reason for that is you've seen changes to the inpatient prospective payment system. You've seen public reporting in the Hospital Report Card Acts and hospitalcompare.gov. These are all things that are catching the attention and the eye of individuals in the C-suite. And if they like or don't like what they see, chances are they want to know who is giving that information out. So if you haven't found your way in, chances are they're going to find their way to your office.
So a conversation is coming if it hasn't happened already.
Yeah, I would be surprised if you'd find a lot of people who said that they haven't had a conversation with their C-level executives at some juncture. And it simply is due to the regulatory changes that have come in the last 5 years, basically. Nobody wants to be the hospital that's listed as the worst in the area. And if they want to talk about infection prevention initiatives, they know they have to talk to their infection preventionists. Similarly, to tie this into the lab, there's a lot of When it comes to surveillance activities, the data that we put out from infection prevention is really dependent on how we're testing and what we're reporting out of our microbiology laboratory. And that is really an intrinsic part of the conversation, the dialogue between these two programs. If, for example, a particular laboratory is not speciating blood cultures to a certain level, it makes it difficult for the infection preventionists to determine whether or not that is a line-related infection or whether it may be attributable to a secondary site. So a dialogue that needs to go on between the two programs, both with respect to workflow and common goals and a shared vision.
One of the other things that you talked about in our phone conversations were these meetings.
Yeah.
Tell me about the meetings.
Yeah, these are great actually. So instead of having just a standalone infection prevention program staff meeting, we actually have a staff meeting that splits into two. And the first half is usually joined by our medical director of microbiology, the microbiology laboratory manager, the individual who does our pulse field gel electrophoresis work, as well as the individual who helps to develop some of our molecular diagnostic tests. They join us for the first portion of the program where we talk about shared objectives, shared projects, both research related and otherwise. So the situation I've described where we talk about Clostridium difficile testing and developing a new test and how to roll that out, that's a product of these meetings. Similarly, when we have an outbreak investigation going on, those are usually discussed during that first half of the meeting. Outbreak investigations are also discussed during this shared meeting time period. And what this does is that, if for instance we've determined as part of our outbreak investigation environmental cultures are needed, it gives the microbiology lab a chance to gear up for those tests, make sure that they have adequate supplies, they have adequate staffing to determine the appropriate number of cultures that need to be taken, who those reports need to go to, and what are the action items thereafter. So it really is a shared approach, often mostly geared towards infection prevention initiatives, but bringing the microbiology lab into that discussion so that if infection prevention thinks, we need to do 200 environmental cultures and the lab says, whoa, don't bother collecting those because we don't have the media or the resources, can we help prioritize where these are at? We're able to have that as a very interactive discussion between the two to where we find a common goal and we say, that's what we're going to do, that's where we're going to go.
Mm-hmm. So these meetings are, it feels like they're a really valuable tool, like they're something extraordinary, the way you describe them, and the way Lance describes them too. I get that sense from both of you.
There's something going on there because you have two things. Not all infection preventionists are microbiologists. That's probably not a surprise. You've got individuals with nursing backgrounds, public health backgrounds, allied health, and it gives them an opportunity by having this dialogue with the lab in microbiology on a regular basis to learn more about microbiology, learn how workflows impact the laboratory, and it broadens their knowledge. Similarly, the microbiology laboratory staff that join us are able to both understand and contribute to the discussion about how their work impacts and influences the infection prevention program. So I think it's a mutual personal benefit, and by having these discussions earlier, we're saving resources. We're able to not only streamline workflows and work processes, but also how patient care is related. So for instance, we had a circumstance where we have a shared electronic medical record for all of our hospitals and a centralized microbiology lab at one of our hospitals. When we have a patient that's identified with a drug-resistant organism warranting contact isolation, an isolation cart needs to be ordered. So if you talk about how this often works in other centers, a laboratory personnel will final result, the infection preventionist will receive that report either immediately if they're using a surveillance technology system, or sometime later in the day or once daily or however often they're reviewing their micro reports. They will call the floor, notify the nurse who then orders the cart. So from the time that you know that a patient has an organism that warrants contact isolation to the time that the patient actually gets on isolation can be several hours, up to maybe even a full day, for example. In this system, what we have is when the multi-drug resistant organism is identified by the laboratorian and they're resulting it, they also order the isolation cart. So that goes up to the floor, which notifies the nurse, as well as the electronic medical record, which notifies her of a new result. So she knows that her patient has a new multi-drug resistant organism, and all she has to do is hang the sign. And that cart is up there within 40 minutes.
That's remarkable.
It actually saves, time. If you think about the number of times people go in and out of a patient's room throughout the day, and if it's delayed by several hours, the number of opportunities that those organisms can be transferred either to healthcare worker hands or the environment, where they can be transmitted to another patient more easily, by narrowing that time frame, by simply changing a minor workflow, it saves everybody time. It saves the laboratory from having to call the nurse or call infection control. It saves the infection control professionals time in terms of reviewing the results and ordering the cart. It saves the nurse time, and it gets the patient on isolation quicker.
That's really special. And that's so that just by bringing people together and having them face this creativity arises where they're able to kind of.
I think it came out of an express need of why did this patient take so long to get on isolation precautions, and we had walked through what had happened, identified, well, there's opportunities for improvement here, here, and here, and by the time we were done, we thought, well, this will work better, and everyone at the table was happier, and then we started clocking how long it actually took for the patient to be isolated, and the patient's outcomes are better.
So, as we look at this convening of people tonight on the stage, we're going to be talking about, again, how we improve collaboration between the lab and IPs.
Yeah.
And we're not attempting to reconcile or solve problems, right? We just want to float issues to the surface. We want to identify areas of opportunity. We want to name challenges. And then, hopefully, what APIC and ASM are going to do with the resourcing that Roche is providing is that they're going to start designing and providing products and services over the year ahead that will actually impact the way lab technicians and IPs work together in hospitals. What do you think, can you just dream for a second with me? What would be the kinds of products and services, or how would this roll out, or what would you imagine would happen that would actually make a difference in the world?
I dislike the use of this word, but I think a toolkit is really needed because this is a multifactorial issue. There are communication needs that are out there. So, for example, by having two different cost centers reporting up two different arms of administration, there isn't a mandate that they interact with one another. The most common interactions, my sense is that it's one direction. Lab, we need this done. And we need a way to facilitate, and I don't know if it's by case study or something else that talks and addresses this issue of communication between two freestanding cost centers with mutual and shared interests. So I think we need to make that case of why this is of shared and interest to both the lab and the infection prevention programs out there. The second thing I think that they need is some practical examples of what this looks like and how it works. And the third, and probably one of the more useful examples, is going to be how to build this business case for when both the lab and the infection prevention programs have a new initiative that's going to cost more money, that will result in better patient outcomes and better workflows, and how to work together to get that done. So I think that when we're looking at this, we really need to look at setting a shared vision and articulating the needs and to get us there. And I would say communication, education, and business cases are probably the three best ways to do that. And then it's really going to be up to the organization, the institution, the individuals in there to make that commitment that this is something that is a benefit to us and is worth pursuing. You can imagine that in any hospital it can be political, so you need to put those things aside and say, in the interest of the patient, the best way we can accomplish this is by having a shared vision and a shared goal, and how do we get there from here?
We really got to get stories out there where successes have happened. Stories are one of the primary ways information travels.
Yeah.
If we give people 16 bullet points, tomorrow they'll be lucky to remember one.
Right.
You tell them a story, and 3 weeks from
story.
now, 3 weeks from now, it'll be in there. So I want to get your story out there. That's
I think one of the stories that I didn't articulate on during the shoot that is the negative example, and I think we talked about this on our one-on-one, where I worked in another place where that communication wasn't as bidirectional or as collaborative as it had been in other institutions, where the lab changed their susceptibility panel. That notification never got back to infection prevention and control, and our automated surveillance system missed an outbreak. That's unfortunate. I mean, that was a contributing factor. You can't rely on automated surveillance systems to detect outbreaks. That's first and foremost. But they can certainly help provide an early warning system. But if you have that absence of communication, you can have that kind of event occur where you could have done something 2 days ago, but you didn't because you didn't know. And I think that's really an important point.